This is Atraumatic Care of Children and Families from Kyle and Carmen's textbook, Pediatric Nursing. So, principles of atraumatic care. Our definition is that we're going to give therapeutic care to prevent or eliminate psychological and physical distress. So really the three things we're going to do is prevent or minimize those physical stressors, things that cause pain or distress. Prevent or minimize parent-child separation. So this includes things like letting the parents stay, providing the parents sheets so that they can sleep at the bedside there, and then promoting a sense of control. And we're going to do this by preparing children before we do any kind of procedures or anything to them. And one of the ways we do that is by using our child life specialists. They're experts in preparing children for hospitalization or procedures, of knowing how to talk to them and what to do to prepare them. They also are great at support during procedures. They are the ones who play with the kids, supporting normal growth and development. So they know what's appropriate toys and different play activities for various ages, taking into account their illnesses. They're good with sibling support. They will make sure that the siblings are not home frightened, thinking something much worse than is actually happening is going on. They advocate for the child and the family in that way. And then they're also trained in grief and bereavement when we do lose a child, and they'll work with the siblings as well as the parents. So how do we prevent or minimize physical stressors? Well, during procedures, we want to make sure that the child has some control. So ask the child what is going to make them feel better. They may want their special teddy bear with them, or their special blanket. Use comfort positions, and I'll show you a picture of that in a minute, which includes therapeutic hugging. And then use distraction, music, conversation. Talk to the kid. Ask them to tell you about their favorite movie or their favorite TV show. So here are some comfort positions. We used to strap kids down and do procedures, and they cried through the whole thing. And we found that if we have a parent holding them with just the extremity we need exposed, they don't cry as loud or as long. So you can see if you need to do a heel stick, you can have the parent be there holding them with just the foot out. If you need to do an IV or a blood draw, have the parent holding them with just the extremity you need. Some ideas our book gives us for distraction. I just think this one's really specific, but it would work. Have the child point their toes inward and wiggle them. So give them things to do. Talk to them, then have them trying to do things. Squeeze your hand. Have them count out loud. Have them sing a song with you. Have them, this is assuming there are pictures on the ceiling in your treatment room, so have them point out the pictures. Have them blow some bubbles or play some music that they like. Really anything. What do you see in the child's room that child's interested in? Ask them about it. Have them tell you about it. Anything to distract them. And how about family-centered care? So we want to respect the child and the family. And don't limit this to just the parents and siblings. We may be using more than that. This is where you've really got to take into consideration culture, race, ethnicity, socioeconomics. What you would want done may not be what they would want done. And so family-centered care means doing what is helpful to them. So let's identify what strengths they do have and build on those, and find where they are lacking and work on helping them with those. The family gets to make the choices related to a child's health care. It may not be the choices you want. This is their child, their family. They have to live with these choices the rest of their lives, so we're going to support their choices. And that's going to require you being flexible, because some families are not going to make the choices you would have. So continuing on with family-centered care, always be honest. Sometimes we have to give bad news. Parents are asking for reassurance. Are they going to be okay? We can't always promise that, but we can say we have great doctors, great nurses here. We are doing the best care your child could get. We can tell them that. We can't tell them it's going to be okay. So honest, unbiased information. Use an affirming tone and a helpful approach. And I'd say not just with the family, but with the child. Don't go in acting like you're frightened. That is not going to help to relieve their stress one bit. So affirming and useful tone. Convey information in a way that will be successful for learning. So don't give them written information if they're functionally or illiterate. Don't give them the information in English if they don't read English. So you've got to make sure you're giving it in a way that they're going to be able to learn it. Assist with emotional support. Family-centered care includes emotional support as well as the physical things we're going to be doing. Collaborate with the families. The family knows their child a lot better than you do. They're going to be able to tell you if this is normal or not normal, or if the child seems to be getting better or not better. Especially kids with chronic illnesses, the families can pick up on subtle little things that we would not see because we don't know the child as well. And then our goal is to empower the families. We want the families to feel capable of caring for their child, to have the equipment they need, to have the knowledge they need. So some of the positive outcomes when we do use family-centered care is decreasing anxiety, which makes the children calmer. It makes their pain better managed. Doing those things makes recovery time shorter. Families become confident in their problem-solving abilities, that they feel like I can do this, I know what to do if something happens. We improve communication between the family and the healthcare team. Very often people leave and say, I don't know what my doctor said, I don't know what my doctor wants me to do. But when we're really doing good family-centered care, there's better communication, better understanding. By doing all of these things, kids are not in the hospital as much. We can send them home earlier because we've trained the family and empowered the family to do a lot of the care at home. So decreased hospital costs. And it means our healthcare resources are used more effectively. So you can see, to keep the kid happy, we give the parent a bed. So how do we provide a sense of control for the hospitalized child? Well, we need to communicate and we need to teach them what's going on, but we need to be aware of their age and developmental level. And notice those are two separate things. Some children are very mature for their age, and we have a lot of kids with delays. So their developmental level may be considerably behind their actual age. And listen attentively. Observe nonverbal communication that you see from the family. So if they're crossing their arms and glaring at you, they're either not agreeing with what you're teaching or not getting it. Again, be positive. Don't give false assurances, but be positive. And then assist the family to obtain what they need for information and resources so that they can take their child home and be successful caring for them at home. Often we work with an interpreter, and it's trickier than it seems like it should be. It's best if you can prepare the interpreter ahead of time. Remember, they're just the communication bridge. They are not the content expert. They may not understand the things you're trying to convey, and that's going to make it harder for them unless you can go through it with them in advance. Speak slowly and clearly, but avoid jargon. Try to not use those medical terms that we're used to, but may not translate well and may be difficult for the interpreter to translate. Don't give too much information, so pause every few sentences. You want to give small pieces, let them interpret it. Small pieces, let them interpret it. When you are using an interpreter, look at the family, talk to the family, even though the interpreter is going to repeat it. We want the family thinking that we're talking to them, not that we're talking to someone else. So that's one that often just gets missed because you're saying it to the interpreter, but really you're saying it to the family. So look at them. Give everybody enough time to respond, and then ask the family to repeat it back to be sure they've understood. There's no way of knowing they understood. Nodding and saying yes is not a guarantee that they actually understood. So have them repeat it back. Avoid side conversations. Again, this is easy to do. As the interpreter's saying it to the family, it's easy to turn to the other nurse or the physician or somebody. That really makes the family feel left out, that you're talking about their child without including them. And then not everybody is a good interpreter. Just because they speak the language doesn't mean they do a good job interpreting. And or our book uses interpreter, really translator is the term we like to use. And then you really don't want to use children. Can you imagine how awkward it is to have the child asking the parents about their sexual history or sexually transmitted diseases or whatever. So it's always best if we can use the hospital-trained interpreters. We know they know the medical terms. Some families want to use their own family member. They're more comfortable with that, but it's still good to have the hospital person there who can just ensure that what's being translated is translated correctly. So moving on to communication. Here's a couple pictures of communicating with kids. The first one, she's giving that girl time and really focusing and paying attention to what the girl says. The younger boy is getting to try out the equipment, touch it, play with it on a stuffed animal or something else first, which takes away some of the scariness rather than just throwing it onto his arm and trying to do his blood pressure. So let's look at different ages. When you communicate with infants, our goal is to respond to them. So when they're crying, come and take care of their needs. Some infants need a little time to warm up, so don't force yourself on them if they need that time to warm up. Always use a calm and soothing voice. If they're an older infant, try and play with them. And if they're hiding from you, you can play with their stuffed animal or something in their bed until they start to think you look like you may be safe, and they kind of come over to see what you're doing. So communicating with toddlers. These guys usually are afraid of strangers, so approach slowly. Do things in the room first. Talk to the family. Don't just come straight in and start touching and prodding at them. Use words that they're going to understand, and you may need to listen. What words do they use for going to the bathroom or for whatever medical thing it is you're doing? Don't use terms they don't know, because that can be very scary. Try and use toys, stories, dolls, books. Incorporate play into what you're doing. Try parallel play. At this stage, kids play the same thing, but next to each other, not interactively. So if they're playing with their stuffed animal, can you find another stuffed animal in their bed and start doing what they're doing, which is what they would expect another toddler to do. And so now you're getting less scary. For these kids, we do want to prepare them before we do things, but it's just right before. So don't tell them they're going to get a shot or a poke or whatever until you're about to do it. But warn them before you do it so they know they can trust you when you say there are no owies coming, because you told them even though it was immediately before.